All right. So welcome everybody. For those of you who don't know, I'm Jacqueline Wynn, President for the AMA Alliance. Established in 1922, the AMA Alliance is the nation's largest organization representing the physician family. All across America, we have members and alliances that exist at the individual, the county, and the state levels. We are physicians and physician spouses and partners whose mission is to build healthier communities. As I stated, the AMA Alliance is a 501c3. That means that while we are a nonprofit, we also can still advocate. In fact, we state that we connect, advocate, and educate. Therefore, one of the biggest benefits of being an AMA Alliance member is our partnership with the AMA. They are on the front lines of legislation and advocacy, and we thank Cynthia for being with us here tonight. I'd like to get us started and introduce Beth Irish, who is a dear friend and truly a mentor to me. And she has been instrumental in really keeping the Alliance connected to the pulse of legislation. Beth's career as a critical care RN, lasting almost 25 years, allowed for development of a knowledge base and economic understanding of the many issues confronting the patient and the people who provide their care. Since becoming active at the national level Alliance, she has found a purpose and direction working with healthcare policy and advocacy. She served as the AMA Alliance's liaison to the AMA Council on Legislation, and now that fuels that passion to support the AMA physician and their family. Beth has, at the Oregon Medical Association, Beth has been section chair for the Alliance, serving as a voting member on the OMA's Board of Trustees. Currently, she is your legislation chair, and she is also on the Board of Directors and director of the Programs Council. Beth, I will turn it over to you.
Thank you very much, especially for the kind words. I am so pleased to introduce you guys to Cynthia Brown tonight. Cynthia is the Vice President of Government Affairs in the Washington office of the American Medical Association. She oversees the AMA's advocacy efforts with the US Congress and all of its federal agencies. Prior to joining AMA in 2008, she worked for the American College of Surgeons for 21 years. And most recently there was director of their division of advocacy and health policy. Cynthia got her bachelor's degree in poli-sci from Northwestern University in Evanston, Illinois, and her master's degree in poli-sci at George Washington University in Washington, DC. A few years ago, I have to tell you this story. They love it when we tell stories, and now I have a story to tell about Cynthia and I. A few years ago, when I was first preparing to introduce her to a group of our Alliance members, I was so nervous, and I wanted to have all my ducks in a row and all the bases covered. So I said to her, well, what are you going to cover? How will you do it? After a short pause, she looked at me and she said, well, Beth, I will give them an update on what we've managed to do, what we want to do, the environment we're working in, and prospects for getting these things done. Then we'll open it up for questions. Does that sound okay to you? And I say that to all of you now. Does that sound okay to you? Because I have found over the years, you deliver so well on all of those points, and don't be afraid to ask questions at the end. Let me introduce you to my friend Cindy Brown and the VP for Government Affairs at the AMA.
Well, thank you very much. Let's see, I'm not muted, so everything should be good, right?
Yes.
I'm terrible with Zoom, but let me try. I do have a couple slides. Beth thought I needed some.
Jacqueline may be able to pull them up for you. She has the PowerPoint.
Oh,
Yes.
no
Cynthia,
kidding.
would you like me to run your slides, or would you like to run it from your computer?
Let me try and do it first and see what I can do. Let's here. I want to go here first. Wait. Am I successful?
Yes,
Good.
it's up.
Okay.
May update.
Well, here we go. This is the first slide that's most important. This was the thing that we thought might be most helpful for people to see.
Just time you get.
Sometime last year, you know, the AMA's agenda in Washington is very, very broad, right? And it covers a wide variety of issues, and an awful lot of things come at us that, you know, wouldn't be our choice. It's just things that are happening in Washington that we need to do. And we felt that a lot of our major work was getting lost in the shuffle. And so for clarity for our members and also our lobbyists so they can keep their eye on the prize, AMA came up with this recovery plan for America's physicians. This sort of builds on the idea of COVID recovery. Now physicians have been through it all. Time for the physicians to have a recovery plan. So much of our work centered on these sort of 5 pillars or 5 elements of our plan. One of them was to support telehealth and maintain coverage and payment, because that certainly was something that helped an awful lot of patients and physicians during the pandemic. Scope of practice. That is starting to change a little bit from a state issue to a federal issue, unfortunately. Deal with burnout issues and things like prior authorization reform. Reduce burnout and stress, and you know the stigma associated with physicians who get help. You know, basically like the Lorna Breen story of the young physician who ended up committing suicide because she felt she couldn't get help for her depression during COVID because she thought it would ruin her career. And there's a lot going on there. And then reforming the Medicare physician payment system. Now, last year, even though it was a real challenging year and it was an election year, we achieved some successes on all of these. Telehealth coverage is now going to be supported by Medicare through 2024. And that will buy us some time to show how it is being used and to show that it's not going to break the bank. Because honestly, we were trying to get this done, have Congress do this in law indefinitely, and the Congressional Budget Office, which sort of sets the ground rules for these things, said it would cost $16 billion, and we weren't going to get $16 billion to do it. So we had legislation pass the House, big bipartisan majorities, but they couldn't get it through. So anyway, so now we did get it through, though, for the 2 years, and this allows us to collect the data and so forth. Scope creep, we've managed to stop all of them on the federal level, but they're still there. There was a bill introduced late in the year. They had the wish lists of every non-physician clinician you can imagine wanting to get full authority to do anything they want. You know, we let people know that we would oppose it, but we do expect to see it back this year, and you'll probably be seeing some stuff from us on this. And of course, on the state level, they're always fighting it. Fixed prior auth is another thing that we managed to get through the House. Again, though, it was too expensive, but the administration now has issued several regulations that we're working on that seem to do most of what the legislation would do. So we're still working on that, but we think that's pretty well covered. Burnout and the stigma issues, again, we're still working on that. We did get the Lorna Breen Act passed. There was in the end of year package something that would help let hospitals provide resources to physicians and so forth without it being an anti-kickback thing. And then reforming Medicare physician payment. We were able to lay a lot of the groundwork for reform. We were able to mitigate the cuts that were in store for January of this year. But that is still something that we're working on, and that's going to be a huge focus this year. I'll get more into that. This is what we managed to do, you know, in a nutshell for physician payments this year. Originally, they were supposed to be, our 2022 conversion factor was $34. They were going to decrease it to just barely over 33. With the legislation we're able to pass at the end of the year, the conversion factor's up to almost $34. So some achievements there. It's not what we wanted, but it's good as we can get. This gives you sort of the real problem with Medicare physician payment. Over the past 20 years, we haven't gotten a real physician update, which means no money has been injected into the system. There has been no inflationary update. We're 22% below the rate of inflation already. We're the only people who don't have an update in law like that. And this is the thing we need to fix. All our other problems are really on this. The budget neutrality adjustments that have been giving us headaches throughout the pandemic, those would not have hurt so bad if we had an inflation adjustment. We could have survived them. We wouldn't have had to seek legislation for them. Similarly, the budget neutrality proposals. This is a little weedy, but one of the things we're going to be looking at this year is to fix that system. What happens is, for example, the most recent problem, or the problem of a good thing, was they revised the coding and payment policies for office visit services. It redistributed money to primary care. By redistribute, they mean they had to do budget neutrality because the payments went up so much for primary care services, which are, the biggest thing charged under the Medicare fee schedule. They offset the increased total expenditures by cutting payments across the board. And the original was over 3%. We had another adjustment like that this year because they did a similar thing for facility-based visit codes. And now we're looking at one coming up next year because there's this snooze. My computer keeps wanting to restart. There's this new add-on code for complex office visits that, again, will probably cause another 3% cut in the conversion factor for budget neutrality. We need to get rid of this. So we're looking at a couple things. One is that some of the budget neutrality cuts we've had on the past were because the CMS actuary overestimated how much the utilization would be. And in some cases, they expected it to be billions of dollars, and it ended up in just a couple million. But that money was already taken out of the system because of budget neutrality. There needs to be a mechanism for when they make a mistake, they can go back and fix it and give us our money back. So I think that's the first thing we want to look for. We also want to, right now, services that are subject to budget neutrality are those that the actuary estimates will cost over $20 million. That needs to go up. That number was picked in 1992. We've had a lot of inflation since then. It needs to be a higher threshold. And then finally, we have to be more precise in defining the kind of policy changes that are subject to budget neutrality. Excuse me, this add-on code they're coming up with at the end of the year, we don't think fits. So that's going to be our first effort, is to go to the administration and talk to them and try and get that changed so that they don't apply budget neutrality. If they do, we're going to have to go to Congress with these asks. I'm sorry, I always cough on calls. So I can get out of this now, I think, if I can figure out how. There. So those are kind of my slides in a nutshell. We were able to get other things done this year, a lot of things that weren't part of the plan. For example, they made permanent the option for Medicaid to cover postpartum women for 12 months, which is something we've been asking for a long time. Puerto Rico, has a horrible time with Medicaid. We got their enhanced Medicaid match extended for 5 years. They added some new graduate medical education slots. They did this again last year, surprisingly. They added 1,000. Now they added 200 more. Clearly, we've been looking for this for decades, and they're starting to do that. So half of these 200 they came up this year, half of those will be for psychiatry and the related specialties. There's also a really interesting provision we got through because everybody wants student loan forgiveness and it's way too expensive. But to help people with high student loan debt, if they're employed by a company that provides employer match for retirement savings, starting in 2024, you're going to be able to count your loan repayments as your contributions for the purposes of getting your employer match. So you may not be putting your own money in there, but the employer will put a match in there, and you don't lose those early years socking money away that grows so much by the time you retire. At least you have a way to sort of mitigate that problem. So this was something that was definitely something the AMA owns. It was our effort to try and do something about student debt. And also medical marijuana. That's something we've been looking at for a long time. I mean, you know, if there's supposed to be medical uses for marijuana, what are they? Somebody needs to be able to actually do the research with the strains that are relevant and find out about dosage and find out what works and what doesn't, and do clinical trials and all that. And it's not that we support legalization or anything, but if you're going to call it medical medicine, then you got to treat it like medicine and figure out what works and what doesn't. And we did get that through, which is something we've been working on for a while. Now to get also just an idea of some of the things, again, the broad effort of what we do, just to quantify it a little bit. This year we sent out 146 official correspondence from my group. About 63 of those were comments on regulations. If any of you have seen our regulatory comments, they're frequently 40, 50, 60 pages long. They can go to over 100 pages. When you're commenting on the Medicare fee schedule or something like that, it's enormous. So we're being very productive and we're getting a lot of information out there. I would also say, you know, we've also have a very robust grassroots program. A lot of people wonder just what all we do because they don't see it all. Part of it's because a lot of it we target to certain legislators because it's very expensive. And if you're going to run ads and that sort of thing, you really want to go to the people who are going to be in the room when the decisions are made. So like, for example, we pay people to make phone calls or we, you know, to recruit people to make phone calls. And we did that. We got about 10,000 phone calls to Capitol Hill this fall. We had about 135,000 emails sent from physicians and patients to Capitol Hill. Again, that's kind of what it takes to get all this done, to try and get these things moved. So looking ahead a little bit, as I mentioned, Medicare payment reform is going to be the top thing. We're going to push those two issues I mentioned, the inflationary update and fixing the budget neutrality methodology. There are a lot of things we want to do with pay for reporting and pay and that sort of thing as well. Those things are still being fleshed out, but I think the top priority is just to get money into the fee schedule somehow. But it's going to be hard. We did manage to get the point across during our educational efforts last year that clearly MACRA, the Medicare Physician Payment System, is in need of serious repair. They get that. We've had promises that they're going to do some kind of hearings and roundtables and things, sort of a MACRA oversight kind of thing, to hear from us what's wrong with it. And we're going to, you know, keep pushing to make sure those things happen. But the term reform means different things to different people. And I think this audience probably gets what I mean by reform, to make the system work better for doctors and patients. But there are some now who look at reform as cuts. And they want to reform entitlement programs in terms of having them cost less money. That does not bode well for us. That's going to be a challenge we have to deal with. You know, what is reform? There's probably going to be a lot of things coming up on Capitol Hill this year that might put us or attempt to put us in defensive mode as well. You have no idea what kind of screwy ideas people are going to come up with. And so we're always going to have to be ready to respond for those. But again, what we want out of Congress this year is going to be very expensive. There's also going to be a lot of pressure on policies that we've supported for a really long time, like the ACA and access to care under things and under those programs. You know, what to do about disadvantaged communities and social determinants of health and those kinds of things. Those are going to be difficult. One thing, regulatory relief could be a good sweet spot for us with this Congress. Depends. Sometimes they use regulatory vehicles as a way to save money. That's where we ended up with all the quality reporting. If you didn't do it, they could cut your pay. So, but you know, that's something still we may be able to get. Also support for physician-owned hospitals. As you know, they can't expand anymore. A lot of pushback from the hospital associations on that, but the Republican Congress seems sympathetic to that. So hopefully we'll be able to get those done. Also, Congress is going to be distracted a lot by oversight and hearings. You've probably seen the stories on the news tonight about what they're doing to the Government Oversight Committee, and it's all election deniers. So, I mean, they're going to be tied up with issues like that, and it's going to be hard to get attention for ours. You've got the debt limit crisis. Again, they want, there was some deal cut about what the conservatives will have to get in order to pass the debt limit, which is must-pass legislation. We don't know what that package of things might be yet. We don't know what future it holds for the things that we're going to be asking for. They say they want to do all the appropriations bills in regular order, all 19 appropriations bills. The reason we have a big end of year package every year is Congress never gets all 19 appropriations bills done. Gets the Department of Defense done, might get a legislative branch, a few others, and they never get health, which is why we're always in such a package. In reality, there should have been a package on health things that passes in September every year. It never does. Since I've been in Washington, I think once they passed all the bills, and I'm going back, I started working on the Hill in 1982. So they just don't do it. They do these big consolidated bills. So again, we'll have to see how that impacts what we're trying to get done. But again, we are a nonpartisan organization. I think the problems of getting things through aren't going to be with us or our messages or what we're asking for, because we're really asking for things that ought to be bipartisan. But we are probably going to run into snags where the House and the Senate bump heads on what they want. And again, we're going to have to worry about the cost. But why don't I just stop there and take any questions you folks might have?
Okay, I'm going to lead off very quickly. You referred to the ACA, and that's going to come up for discussion. And you have concerns about what will happen with it. Is that because of the cost issues continuing to rise for using that plan?
Not really. I think it's just old wounds.
Okay.
There were some expansions that were provided as part of the COVID relief and so forth. And they, for example, the administration's dealing with the family glitch, where if you're trying to cover a family under your employer-sponsored coverage, the affordability factor, where they decide if you get subsidies for the coverage, is based on individual premium, not family. So if your family afford, they'll say, well, they're judging you on the wrong yardstick. They think you can afford it because they're just looking at the single coverage. And family coverage is usually a lot more. They usually subsidize the employee a lot more than they subsidize the employee's family. So, things like that. The Medicaid expansions and so forth, nobody quite knows what that's going to be and how that's going to be rolled back. But that's part of it. So just a lot of things like that. I think it's both, like I said, ACA sort of sour taste in the mouth, and also money.
Okay, thank you, Cynthia. We have a question from a gentleman, Warren from Illinois. He would like you to explain the conversion factor.
Okay. It's a mess. The Medicare physician payment system is a real complex formula that accounts for everything except inflation. I have a slide, but I don't want to dig it out right now, but it's very complicated. So they look at the physician fee schedule, which is broken into 3 components: work, practice expenses, and professional liability costs. And the values for those are established through surveys and all kinds of things, where they figure out, this procedure is twice as much work as that one, so it gets a 2 for work instead of a 1. The costs for it are much more expensive, so it gets twice as many practice expense values, and so on and so forth. But in the end, all you've got is a number when you add all these together. you have to multiply it by a dollar conversion factor to turn it into a payment. So something that has relative value of 1 right now would be paid just under $34. So you can get a sense. If you have a service that's worth $300, it's about 10 RVUs, that sort of thing. So that's what the conversion factor is. And since that turns it into dollars, it's a convenient tool to use when you're trying to achieve the budget neutrality. If you don't want to spend more money tomorrow than you spent today, but you change the relative value unit so that somebody's services are worth a lot more, you take the cut on the conversion factor and it goes across to everybody. So then even the people who provide, say, the E&M services are not getting as big an increase as they would have gotten because they get the reduction also. Does that make sense?
Rachel has typed in, so conversion factor equals dollars per RVU.
Yes,
Good.
it's a dollar
By the same
multiplier.
token, you know, Cindy, we've got to remind everybody we're very behind relative to inflation, bringing up that point once again on payments
Exactly.
to physicians. It's just so far behind.
Correct. You know, most other, like hospitals, they get what they call a market basket update, and there may be adjustments on it, but this year it was like 4% or in that neighborhood, and they got a 4% increase. Even without our budget neutrality, if we haven't had that, we would get a 0% increase. And it's not because our practice costs haven't risen. Ours too, they calculate to be about 4%. But inflation is not in our payment formula.
Yeah.
And it was done by somebody to save money. When they did MACA reforms, we told them at the time, we're going to have to come back on this. This is unsustainable. The Medicare trustees in their report last year said, this is unsustainable. Even MedPAC now, which is an advisory committee to Congress, which never takes our side, has said, well, maybe next year we ought to give them at least half the MEI. So we're making headway. It's just a matter of getting somebody to open the purse strings.
So when you say that MedPAC doesn't take your side, you mean they're not taking the side of AMA, which is organized medicine representing the physicians, correct? But
yeah, or I just say physicians. Like I said, they always say, well, Medicare patients have access to their doctors, therefore payments are adequate. So fine, keep the payments frozen.
Huh.
I mean, they've got blinders on to what's really going on.
Yes. I've got another question while I wait for somebody to type in here. You commented that the physician-owned hospitals, they can't expand anymore. Are you talking about merging and becoming bigger?
No, I'm
So
talking
that
about being able to have one at all. They froze the ones that were in existence at the time, and they froze them both in size and in number.
Okay.
And, for a lot of physicians, when they're jumping through all these hoops for quality and all that sort of thing, and the money, frankly, is in hospital-based services. They want to own their own hospitals, and it's very popular in certain areas of the country. I think in the West, particularly, I know Texas, they have a lot of them. And they tend to focus on specialties. And a lot of people said, oh, they cherry pick patients. They don't have emergency rooms and all that sort of thing. The quality is not going to be as good. But all the data we've seen says the quality is just fine. The doctors are happier. The patients are happier. Why is everybody allowed to make money off of hospital care except for doctors?
Mm-hmm.
Right? I mean, it just doesn't make much sense. And who's the one that's actually looking the patient in the eye? It's not the hospital administrator, right? It's the physician. So, and we should get more sympathy for that. Whether we can get it through the Senate or not is another question. But some people in good positions now in the House do support the concept of physician-owned hospitals. So I'm sure we'll be pursuing it.
Okay, thank you. Ginger Allen has a question for you.
for taking the time with us tonight. So I have a couple layman questions. Still learning the ropes. I've only been married to a physician now for 10 years. So, and he was already a physician, so I didn't go through the whole thing with him. But my question to you as a spouse, well, I have two questions. Number one is, as a spouse of a physician who's involved with the AMA Alliance, which is a philanthropic organization, and I love organized medicine. I want to support organized medicine. How can we as spouses support what you're trying to do?
Happy to share all our grassroots alerts with you when they start going out. That's something you could do. And even meeting with Congress people, either in the district or in Washington, is helpful with sort of real life stories of what's going on back home. Because we know the policy and we can come up with the options and we can, you know, talk about impacts and so forth. But when people can do it that reflects what's going on in the district or real life, it sinks in a little bit better. And so both those things, you know, just answering the call when it's time to call, and the other one being proactively, you know, going and meeting with your legislators. Particularly, this could drag into the election season. There'll be a lot of town halls and things going on then, you know, for next year's election, because I don't know if we'll get all this done this year. That's a good opportunity to talk to people and say, well, how do you feel about the way the Medicare payment system and how it treats doctors? You know, you can do that and put some public pressure on them.
And can we do that as an organization without it becoming political, or no?
Organizationally for the Alliance, I don't know if it's quite the same. I think what they care about is the people aspect of it.
Right. I
mean, we got the AMA, and we've got, you know, 50 state medical societies plus DC. And then there's about 75, 80 specialty groups we work with commonly. We also, on this one, we have non-physician providers too, who are paid under the same fee schedule. I mean, they're not helpful on our scope of practice issues, but they're very helpful on the payment issues, and they got large numbers and they turn out.
Great.
So we are collaborating with them on that.
You can keep us abreast through Beth or through Jacqueline of grassroots efforts or things that you know we could share that are not necessarily political that could help your agenda. We would love to support you more. And then the last question I have kind of leading into that is, I've always been under the, and maybe the wrong assumption, but the assumption that the MedPAC was for physicians and that we should support MedPAC and that MedPAC should be speaking for our physician families and for our physicians and fighting for their rights. Am I under a wrong assumption?
I think you're being aspirational.
Okay. So can you explain to me why we should encourage our physicians then to pay into PACs?
Oh, I'm sorry. MedPAC is an entirely different thing. MedPAC is the Medicare Payment Advisory Commission. I'm sorry, I'm using a Washington acronym. They used to have one just for physicians and just for hospitals. They merged them into this one. So they do recommendations on hospital patients, payments, home health, ambulatory surgical centers, hospital outpatient departments, doctors, everybody. And they've got a group of people. There are 2 slots on this group of like maybe about 15 people who are physicians. And they tend to be physicians in big systems and that sort of thing. And they just have a different perspective. And they always come up with great ideas for ways to save money on physicians. They never really seem to offer us any help. This thing about just giving us half the credit for inflation next year is the most generous they've been since forever.
So MedPAC is not actually a political PAC.
No.
Okay, that's where I misunderstood. Okay, so what?
Ours is AMPAC.
AMPAC. So the AMPAC is the one we should be encouraging our husbands to, or spouses to support. AMPAC. Yes. Okay.
Yes, and
stay away from MedPAC, but support AMPAC.
I want to say we just quantified some stuff for some end of year reporting, and you know, a lot of the AMPAC stuff goes back to the district and the states and so forth, and the checks get distributed there. But they also they provided 500 opportunities for our lobbyists last year to have face-to-face conversations with Medicare with members of Congress. And sometimes, you know, you have to get around the staff because they have their own biases or they don't get it, or you don't think they're giving the information to their member of Congress, this gives us the opportunity to do it and get the members themselves engaged. And so, no, AMPAC is a very good thing. It's very helpful.
Thank you for clarifying that. I'll let somebody else, I know there's other people waiting to ask questions. Thank you again.
Sarah Sanders, are you willing to speak yourself, or would you like for me to read your question? You've typed in. The opportunity is there, my dear. Okay, she's not popping up. Sarah Sanders, who's a past president of the Alliance, Cynthia, is asking, so if I understand correctly, half of the new resident spots are in psychiatry. Are the remainder spread across the board as far as other areas of care? Are they spread throughout the country? Can we do anything to help fight for more?
We'll let you know when the regulations come out. This just came through the bill that was signed right before Christmas. My understanding is they can go anywhere. They're going to try and target places where there's the greatest need. Same with the ones that they did before. They had 2,000 spots they did before. But yeah, we should know more about, how and all that stuff. But, and again, we're not done asking for more spots. We're also looking for making it easier for, people who want to get green cards and come in as, physicians who need to get their green cards to come in and work so they can work in underserved areas with more favorable terms and so forth. Again, to try and expand the workforce in a way that's free. I mean, these people are already trained, right? All we need to do is get them in this country and allow them to work. So, it's just part of our workforce agenda.
Okay.
I have a question for you, Cynthia. I travel all over the US and I talk to quite a few state alliances and physicians and so on. And inevitably, it does go into like, one time 15 or 30 years ago when the AMA did this, or 20 years ago when the AMA supported this. And, my take on it is similar to a candidate. When will you ever align with somebody 100% of the time, right? But on things that are very, very important, what I try to convey is you have to amplify your voice. And the best way for us to do that is a concerted effort through legislative efforts through AMA or through AMPAC. What is your take, or what is your reply to someone that's upset about maybe a vote or something that you supported and they don't align with you 100% because they were upset about one particular issue way back when?
People go back forever. I mean, lately, we're in trouble for the Flexner report, which was over 100 years ago. Okay, it did, it led to unfortunate events, but it was over 100 years ago. Those people are all dead. And we get it for not supporting Medicare or whatever, in the ACA. And depending on who's writing the story, depends on whether we're the right-wing despots from hell or the left-wing nutbags. I mean, we're one or the other, depending on who's writing the story, and there's not much we can do about that. But I think one thing that is important to know is we do adhere closely to policy. Like before we send out any of those 160 some odd letters, I mean, I have attorneys who sit there and check our policy and see how far we can go and where we can't go and where in that sort of thing. And our policy is set by the House of Delegates, and it's very broad. When I first started working here in 2008, and for a few years, everybody wanted private contracting. Remember that? We all had to do that. Patients were dying to spend more money for your services than what Medicare would allow. If you were only allowed to bill them more, they were in line ready to do it. And we had to do a big campaign, and we did videos for doctors and running offices and things like that. And nobody used any of it, but that's what we were told to do. Now we're going farther, and we're talking about, shackling mothers and in childbirth and things like that, a whole different range of things. And it's all the will of the House of Delegates. So this is what sorts through, and our agenda tends to straddle all ideologies because it represents what physicians are, right? The population of physicians. So that again is part of the reason why we wanted to sort of look at this recovery plan and sort of focus our efforts. And like dealing with some Republican members of Congress has been difficult with some of the things that are going on, whether you're looking at reproductive rights or, you know, all kinds of things. But, you know, every once in a while we have to go in and tell them, look at what we're talking to you about. 90% of what we're talking to you about is in this, you know, in this recovery plan. And just trying to bring it back to the stuff that's important to physicians wherever you are. And it's certainly important to physicians in small and private practices because they're the ones getting hit the most by this. That's all I can think of to do is just kind of bring it back to what we're doing and what the truth is. And realize people have long memories when it comes to the AMA. I still get things from residents who say we control who gets into medical school and who gets into residency programs. It's like, when did you have to appear before an AMA committee? You know, where did that come from? I don't know.
Thank you for that.
You see that a lot.
Yeah, thank you. And quite a few of us on this call actually were at the interim meeting in Hawaii. And I can't stress enough how right you are that it absolutely is led by the House of Delegates. This isn't just something on high, a couple people locking themselves in a room deciding how they want medicine to be. This is representative of thousands and thousands of voices who are practicing physicians. And so I guess, you know, if you're not in the room or you're not at the table, well, you know, you need to be there if you want your voice heard.
Exactly.
So thank you.
Yeah. So Cynthia, let's talk about scope of practice. And I would like for this group to hear from you, speak about it with the idea of the very bottom line, which is physician-led team care. I think too often that term and understanding doesn't get talked about outside of the AMA, or if you're closely paying attention to maybe some of the resolutions on the floor of the House of Delegates. So spend just a little bit of time talking about that with these folks.
Sure. The lion's share of our scope of practice work is handled in Chicago by our state people because licensing is a state issue and that's where we want it to remain. We don't want national licensure. There's been some talk about that because of telemedicine, because people want to have these mega telemedicine companies and, you know, I don't know where, some Caribbean island somewhere and handle, take visits. But we've done a lot of research with patients and focus groups and stuff. And what it shows is that physicians really do want a doctor in charge of their team. They want the people who are the most trained. They want to know whether someone really is a doctor and it's not a doctor nurse or whatever, or doctor's a physician's associate or whatever. They want to know who those people are. And the team-based care is vital. I mean, if you're looking at the sort of care delivery models that are moving and changing and so forth, where maybe like the physician's office may more proactively reach out to patients to manage chronic conditions and so forth, rather than waiting for them to show up at the office. But they actually reach out to them. You know, the physician doesn't have time to do that themselves, but a member of the team could. Or you might have a nutritionist on the team. You might have psychologists on the team. Whatever, but these are all people who can, you know, help you provide thorough care, for lack of a better term, that you can't do yourself, but they're still operating under your direction. They're not, you know, because it's still in the context of the whole patient that the physician has a better grasp of what they need. And a lot gets lost in that. And I think COVID did some of it to us. Pharmacists and other non-physicians really feel that with all they were able to do under COVID, that they ought to get that flexibility forever. And it's like, no, that was a public emergency and it was administering vaccines. It's a little different from managing somebody's diabetes. You know, so yeah, I mean, there's some talk, you know, the pharmacists think they can do an awful lot of diagnosis and be kind of a primary care center. And yeah, we beat all those back on the federal side last year, but it's going to be back. And when you talk about workforce issues, people automatically go to non-physician providers, practicing at the top of your license and so forth. Some confusion of why nurses are allowed to do something in one state but not another. Does that really make sense? Should they be able to do the same thing all over? The VA tries to sneak a lot of this in, so we're working there as well pretty actively, because once somebody in the VA can do something at any VA facility, regardless of state law, you know, you run into an issue there. But we're all about the physician-led team. You let everybody do what they're good at, but it should be in a physician-led team.
Okay, thank you. I understand that Marilee Gober has a question. I don't see it in the chat, but can you pull her up, Jacqueline?
Yeah. Oh, yes. Marilee is typing under Cynthia Brown because they're sharing a sign in. So, so if you look there, it says, "Can you give?" And Asha, Marilee, would you like to unmute?
Yes, I just did. Hi, Cynthia. Can you give the audience just a quick summary of the Hattiesburg, Mississippi data and the VA data that was recently presented at the State Advocacy Summit?
Some of it, and I'm trying to get my picture back up here. Oh God. What Hattiesburg Clinic found out, they were really trying to, you know, it's a clinic right in the middle of Mississippi, I want to say, and it's a huge catchment area. When I was with the surgeons, I worked for one of the surgeons who started it, and it's a
Multi-specialty.
Pardon me?
Multi-specialty.
Yeah, a big clinic, and it's got, I forget how many people, and I'm sorry, like I said, it wasn't, that meeting was run by somebody else, but what they found was they did recruit an awful lot of non-physicians, gave them their own panels and so forth, the patients to take care of. And then they started looking at the quality and the cost of the care provided. And, you know, they did, you know, whatever they need to do to adjust the data for severity of illness, because, you know, the physicians tended to see higher average severity of illness than the nurse practitioners and so forth. And they found the quality care scores were uniformly lower. They didn't even have as good vaccination rates as the physicians did. I mean, you know, getting down to some pretty basic quality scores, and that they referred more often to specialists, and that the care was, they ordered more tests, and that the care was more expensive, which sort of goes contrary to everything what people say the non-physician providers are, that it's cheaper, even counting for the lower salaries, the cost of the care was still more expensive. And, you know, this was just part of sort of an internal audit to see how they were doing. They weren't trying to prove that these people weren't doing as well. In fact, they hoped they were doing as well, because this was sort of a change in direction they had. I don't have, the VA one was brand new to me. I hadn't read that one yet. So when they made the presentation, it was all new to me. So I can't tell you as much about that. I'm sorry.
That's okay. Thank you, Cynthia. We're going to look at winding down because we have a follow-up resource paper that we want to share. Jacqueline.
So, sure. This is the one that you all had, I think Cynthia, you and Beth had prepared. Do you all see this?
No, it came out of our legislative committee.
Oh, perfect. Wonderful. So this is a document that was shared with you all on the sign up and the last info flash. There was a link to this document, and this goes very much towards Ginger's question. Beth, do you want to go ahead and talk about what this document is?
Sure. It's to give you direct links to these sites to be able to be more active at your state and county level. I think beginning with Open States, that allows you to plug in your home address and then go from there to see who your legislators are. And then we also have on there links to the AMA Alliance website with some papers on it that could be helpful as to how to do certain things. And then very definitely links to 3 sites on the AMA website. And the AMA Connect app you can get off of your phone free. And that's a great quick check for all you 35 and unders. Because everything is in bites on that, and it's planned to be that way. So I think it'll be helpful. Please take a look at it when it comes out.
Yeah,
So
do
act-
sign up for those alerts, because those are, sort of the first thing we get out, and then we kind of go to all our other lists, so whether
But
the
if you're not
physicians or the
signed up,
patients.
yeah, if you don't sign up, you won't get them.
So in the chat, actually, I dropped the link to the document. I'm saving you all time so you don't have to hunt for it in your
Okay.
in your own email. So you can copy that.
Ginger, you're asking, how do you sign up? For those alerts you'll see, use the link that goes to AMA Alerts, and they'll ask you for your email, and I believe it's also your state. And then you will get the hits. And you know something we were talking about at our committee, and this may be really helpful to you. There are physician spouses and partners who want to be more in tune with what's going on with their physician work. If you pay attention to the AMA advocacy updates and alerts that come out, and you read them and use it as a point of discussion with your physician, spouse, or partner, you may find that you both have more to talk about. One of the things that came out of our committee discussion was it might stir the doctor to be more interested in what's being produced as well. So take a look at those, please. That would be my plea for all of you.
So first, I would really love to thank Cynthia. You come and speak to us. I think this is your 3rd or 4th year in a row, and we always learn so much from you. And Beth, thank you so much for your leadership. I will share that, and Beth, you might want to say a few words about this, but so this is from the AMA side, right? And this is just an update and so on. But Beth, go ahead and talk about, do you all see my slide here for the next call, the next legislative call?
We're
Great.
pretty excited about it. Sorry.
Yes, so go ahead, Beth. This is the, I'll go through the next January call, but this call is for February. And Beth, go ahead and talk about what's going to happen at this one.
I'm pretty excited about this. We're going to have a panel representing 3 states that have an active legislative advocacy day and or program that's ongoing. And Michigan State has 2 people that will be represented. Missouri, many of you may know Kirk Doan, and Jenny Shepard from Texas. I think it's going to be good. We're going to keep it at an hour. They are going to, each of them, do a 10-minute nutshell. And I've talked with them already. I will cut them off at 10 minutes. So they're learning to put their highlights, their program into 10 minutes, share it with you. After we have the 3 of those, we're going to have Q&A and look at how other people might be able to pick up on ideas from what they present or share, so that we all, as a national alliance, can maybe be more productive in moving this legislation forward. Certainly being out there advocating for what can help support medicine.
Yes, so we know that actually a lot of the younger Alliance members are very passionate and very educated about legislation. And so activating your state legislation efforts would be also a great membership and engagement tool.
Yeah.
And I will leave you all, it is the 6 o'clock hour. I will leave you with one final announcement is on January 26th. Our very own Heather Rifkin, who is immediate past president and chair for nominating, will be hosting a all-member call specifically regarding the nomination process and looking for leadership for next year. So I really just greatly appreciate, Cynthia, you being here, Beth, and each one of you for giving up your evening. Thank you so much for joining us. The video recording for this will be available next week on the AMA Alliance all-member website. Thank you so much. Great to see everybody. I will stop the recording, but if anybody would like to stay on and chit chat for a little bit, you are more than welcome to.
Good, good. Thank you, Cindy. Thank you